Hi, my name is Dr. Harini, and today we're going to be discussing about ventricular septal defects, also known as VSDs. It's commonly asked as a 5-marker or a 3-marker in your final exam papers. So we're going to discuss it under various subheadings. Firstly, we're going to see what a ventricular septal defect is, what are the types of ventricular septal defects, what is the hemodynamics, as well as the murmurs that are heard during this defect, what are the clinical features of this disease, investigations that can be done, treatment modalities available, and the complications of this condition. So firstly, both the ventricles of the heart are separated by a septum, and any defect, congenital defect in this septum leads to various clinical manifestations, and this is known as a ventricular septal defect. So depending upon the location of the ventricular septum, it is divided into two types. So let's assume these are the two valves. This is the mitral and this is the tricuspid valve, and this is the ventricular septum. If the defect is there in the upper portion, that is known as a membranous ventricular septal defect, because this region is embryologically the membranous portion of the septum. And if the defect is in the lower portion of the septum, then it's known as a muscular VSD. So depending upon where it's located, it can be classified as membranous or muscular. Depending upon the number of defects that are there, it can be a single or multiple VSDs. So the defect can be either a single septal defect or there can be multiple defects along the septum, and that is another type of septal defect. And depending upon the size of the septal defect, this is a very important classification. Depending upon the size, there can be a small, moderate, or a large VSD. So a small is when the size is less than 0.5 centimeter square per meter square, and 0.5 to 1 is a moderate, and greater than 1 centimeter square per meter square is a large VSD. And this division can also be made out somewhat during clinical investigations. Depending upon the size, clinical manifestations differ. So these are the types of ventricular septal defects. And now we're going to see the hemodynamics as well as the murmurs and sounds that are heard during this condition. So we're going to draw a box diagram again to represent the heart, with this being the left ventricle and right ventricle, left atrium, right atrium, superior and inferior vena cava, and this being the aorta. And firstly, what happens in a ventricular septal defect is that there is a defect in the septum, and due to the pressure gradient between both the ventricles, there's going to be blood flow through this defect, and this blood flow is always left to right. And this is because left ventricular pressures are higher than right ventricular pressures, and also because the left ventricle contracts earlier than the right ventricle. So blood is going to flow between the left ventricle to the right ventricle, and since left ventricle contains oxygenated blood, this is going to be an acyanotic heart disease, because deoxygenated blood is being mixed with oxygenated blood, as in oxygenated blood is entering the deoxygenated side. So this is going to leave the ventricle and go to the lungs and get oxygenated and come back. So this is an acyanotic congenital heart condition. And depending upon the size of the ventricular septal defect, we're going to see various changes in the hemodynamics. So firstly, because of the pressure difference and the blood is flowing through a small, if it's going through a small VSD, what is going to happen is there's going to be a pansystolic murmur during the entire duration of systole. There's going to be a murmur heard as blood flows through this septal defect. So during systole, the ventricles contract, and because of the pressure difference between these two, blood flows from here to here, and as it flows through the small VSD throughout the systole, a murmur can be heard, and this is known as a pansystolic murmur. This is the first sound that can be heard. And the second that can be heard is an ejection systolic murmur, and this is because the right ventricle now contains blood from both the right atrium as well as blood coming from the left ventricle. There's large amount of blood that is being accumulated in the right ventricle, and this will lead to an ejection systolic murmur at the pulmonary valve here. As all of this blood flows through this, there's going to be an ejection systolic murmur, not because this valve has any stenosis or anything of that sort, just because that large volume of blood is going through a small space, more than what it usually can carry. So that will lead to an ejection systolic murmur at the pulmonary valve. So an ESM can be heard, and all this blood is from the pulmonary valve is going to reach the lungs, and from the lungs the blood is going to get oxygenated and it is going to reach the left atrium, and in the left atrium there's going to be increased blood pressure, and this will lead to a murmur as the blood flows through the mitral valve. And this is going to be a diastolic murmur because blood can flow through this valve, the mitral valve, only during diastole, that is when the valves are relaxed. So that is going to be a diastolic murmur, and a mitral diastolic murmur can be heard as the blood passes through the mitral valve. And this is again because there's a large amount of blood flowing through the left atrium and through the mitral valve. And we're going to hear about sounds. We know that there are two heart sounds, S1 and S2. S1 and S2 comprising S1 made up of the closure due to mitral and tricuspid valve, and S2 because of closure between the pulmonary and aortic valves. So in terms of sound, we're going to hear differences in the S1 and S2 because both these valves are being affected. So there's going to be changes in both S1 and S2. So we're going to see that there will be an early A2, and there's going to be a delayed P2, and there's going to be an louder or an accentuated M1, that is S1 basically. Okay, let's see why each of this happens. Why is there an early A2? So A2 occurs because of closure of the valves of the aorta, and because the blood from the left ventricle is already being emptied out into the right ventricle, there is lesser amount of blood that needs to be pumped out of the left ventricle, and as the lesser amount of blood gets drained out through the aorta, the aortic valve closes earlier as compared to the right ventricle. Now it has more amount of blood, this has to be drained out through the pulmonary vessel, and so A2 is earlier than P2. A2, that is the aortic valve, closes faster than the pulmonary valve because the blood gets drained out faster. So there's an early A2, and naturally P2 is delayed because it's pumping out more amount of blood. It needs more time for the blood to cross through the pulmonary valve, and then it gets closed. So there's a delayed P2. And M1 is accentuated, like we said, because of a diastolic murmur. The closure is accentuated. The blood flows from the lungs through the left atrium and through the mitral valve, and large amount of blood is flowing through this valve. And since after this large amount of blood gets closed, the valves snap back together from this posture to this posture faster after all the blood has been drained out. Large volume of blood has been drained out, so M1 is accentuated. Whether these sounds can be heard clearly on auscultation is it depends. Most of these sounds can get masked by the murmurs that are also already there. So you need to know the two components of sounds that you can. First is sounds that are heard because of the valves, and the other is murmurs. So to sum it up, we can hear a pansystolic murmur through the septal defect, an ejection systolic murmur through the pulmonary valve, and a diastolic murmur through the mitral valve. These are the three murmurs that are heard. The sounds that are prominent in this condition is an early A2, a delayed P2, and a louder M1. So this is basic hemodynamics of the ventricular septal defect, and we're going to see the clinical features of this disease, sometimes depending upon the size of the VSD, the patient can be asymptomatic. That is, they will not present with it up to 1 to 2 years of age group unless and until there's been a trigger for it. For example, there's some sort of exercise or some lesser exercise tolerance. So that can be one of the clinical features. There can be delayed or poor weight gain, and there can be features of congestive cardiac failure because the heart is failing to pump enough blood through the left ventricle out into the aorta to systemic circulation, that is to the brain and the kidney. So there can be heart failure. There can be recurrent respiratory tract infection because now we're seeing that blood is getting mixed into the right ventricle, and more amount of blood is flowing to the lungs. So there can be increased blood flow to the lungs leading to respiratory infections, as well as there can be increased pulmonary plethora, that is congestion in the heart, lungs, increased pulmonary congestion because of increased blood flow that's occurring to the lungs. The patient can also present with classical signs like growth retardation, bound to happen because the heart is failing to function properly, and fatigue, palpitation, poor feeding, and poor weight gain, etc. And they can have frequent chest infections. So what are the investigations that can be done to detect this is first obviously ECG. And in an ECG, what can we find is we can find a right axis deviation, and we can also find left axis deviation, and this depends on the size of the VSD. Most commonly we see a left axis deviation seen in smaller ventricular septal defects because there's left atrial enlargement because of increased blood returning to the left atrium, and a right axis deviation can occur when there is right ventricular enlargement because of increased blood flow into the right ventricle from the left ventricle, and an RBB can also be seen. But then again, ECG in terms of pediatric age group is not the most reliable form of investigation for coming up to a diagnosis. The most useful can be a chest x-ray as well as a cardiac echo. In a chest x-ray, we can see that there can be cardiac enlargement. There can be enlargement of both the right ventricle as well as the left atrium, and we can see that there's prominence of the pulmonary artery, and this is because more blood is flowing through the pulmonary artery, and left atrial enlargement, like I said, and pulmonary plethora because increased blood is going into the lungs. And in a cardiac echo, we can visibly see the ventricular septal defect. We can also see that there is the changes in the mitral valve movement because now more blood is flowing through the mitral valve. We can see changes in the mitral valve movement. We can also see changes in the pulmonary valve movement as more blood is moving through the pulmonary valve. And the patient can also develop pulmonary hypertension as well as pulmonary stenosis further. So these are the three changes that you see on echo. Coming to treatment of VSD, again, medical and surgical modalities available. Now, this treatment will be based on both symptoms as well as the size of the VSD. If the VSD is small, that is less than 0.5, there is more chances of it resolving on its own. There can be spontaneous closure, and so they'll just wait and watch for the symptoms to recede and probably do repeated echoes, and then they'll find out that there can be spontaneous closure of the VSD. Sometimes, depending upon the size, they might require surgery to close up the VSD. It does not resolve spontaneously on its own despite observation, and this can be done using a stent or a patch surgically used to close the VSD. And otherwise, the medical management purely is symptomatic. So you treat the bacterial infection if there is one, you treat the cardiac failure if there's a cardiac failure, and you provide oxygen in case of times when there's dyspnea and tachypnea, and symptomatic treatment if the patient comes in with symptoms for the VSD. Most of the patients with small VSD will be almost asymptomatic. And complications of this disease is, like I discussed before, there can be CCF, infective endocarditis, pulmonary hypertension, bound to happen, very common complication because more blood, there's increased pressure in the pulmonary vessel. And there can be something called an Eisenmenger syndrome, which is basically reversal of the shunt because of the pressure equalizing between the left. This is a topic for another day totally, but in simpler terms, when the right ventricular pressure starts increasing because of pulmonary hypertension and pulmonary stenosis, the shunt which is supposed to be this way can get reversed when the right ventricular pressure becomes greater than the left ventricular pressure, and now this can become a cyanotic heart disease. So this is a complication of VSD. There can be pulmonary embolism, and there can be growth retardation and growth failure to thrive, and yeah, failure to thrive can occur. So this is basically ventricular septal defects. What is of most importance is the hemodynamics as well as the murmurs and why the murmurs are heard. So if you know why the murmurs are heard, invariably you'll understand the hemodynamics and the types of VSD. So clinical features like we discussed, and investigations, ECG, chest x-ray as well as echo. Treatment modalities are both medical and surgical, and complications. Yeah, that's about it. Thank you.